Well, living is about perceiving the change in your environment, classifying it as painful, pleasurable, or neutral, and either thinking and deciding the best course of action to avoid pain and seek pleasure, or using documented past experience to decide that best course. So, medicine till now depended on logical thinking, which is plausibility. For example, if there is bronchoconstriction causing asthma, a bronchodilator should relieve it. So, that is a plausibility or logic based argument. But now medicine made big mistakes, and therefore now medicine depends on documented, credible experience created by research. So let us equip you to deal with creation and use of this documented, credible experience. You are a part of the decision making apparatus for self as a patient. For the patient, you are helping him make a decision as a clinician. For the community, you decide as a health administrator. For the nation, as a health ministry. And for the world, perhaps like a WHO. Now, here let me show you the conflict between a national decision and the decision that was good for the world. When the COVID virus got out from Wuhan, Chinese cancelled all the internal flights from Wuhan and tried to contain the pandemic. But they allowed international flights. So that is how a national decision led to a huge disaster and lots of people being killed. So greater is your level, more responsible and moral should your decision be. In medicine, we are usually moving through this biological model. The normal unit may get diseased, and the diseased may get cured, disabled, dead, or maybe lost to follow up when we do not know what happened to him. So these arrows here are transition rates. The red ones are transition towards bad, and the green one is transition towards good. The red ones have to be braked, and the green ones have to be accelerated. The components of research on this include correctly diagnosing the event of interest, whether disease, whether cure, whether disabled, whether dead, and developing most effective, cost effective protocols to break the red and stimulate the green. So, here is an example of using plausibility for thinking that the operation should help. This half of the brain, if it is paralyzed because there is a clot in this middle cerebral artery. So, since heart supply, blood supply blocked, had been treated by coronary bypass. So there was a surgeon in Saskatchewan district who anastomosed this superficial temporal artery to the middle cerebral artery to beautifully restore circulation in patients who had a clot in the middle cerebral artery and had hemiplegia. Coronary bypass was successful, so the cerebral bypass took off, and very soon we had large number of patients being operated at lots of cost in many centers around the world. In a presentation of the operation in Boston, asked the speaker But sir, where are your controls? That means what happened to those patients where the operation was not done? That angered the speaker, and the angry speaker said, "Do you mean to suggest that I would have left half the people to die?" But there was some funding agency person also in that conference, and he decided to have a comparative trial between operated and non-operated. And that was a randomized controlled trial, which was multi-center, done at all the places where the operation was being done. And the results of the trial proved that those who were operated were at 6 times higher risk of dying within the first year as compared to not operated. This randomized controlled trial was a lesson for the world not to use plausibility, and this actually stopped this operation. No further operation was done in patients of stroke on this basis of plausibility. Two things that you can learn from this slide is that this was the 2 by 2 table. Here were the operated, these were the operated patients 100, and these were the not operated 100. 36 out of the operated died and 6 out of the not operated died. Now if 36 upon 100 is the risk of dying in the operated group, and 6 upon 100 is the risk of dying in the not operated group. Therefore, 36 upon 100 divided by 6 upon 100 is the risk ratio, which tells us that there was a 6 times higher risk of dying in the operated group as compared to the conservative group. Now, this is called as the risk ratio. And after this number 6 that you see here, you also see this lower upper and 2.6 here and 13.8 in the upper limit. So this lower upper is the confidence limit of the 95% confidence interval estimating the risk if you repeat the study 100 times, which means that if there are 100 such studies, then the risk ratio would range between 2.6 and 13. Now, as the sample size increases, this interval or estimate becomes narrower and narrower. So, confidence point estimate and interval estimate is the second thing that you have to understand. So, first thing is what is risk, the second thing is what is risk ratio, and third thing is the point estimate and the interval estimate. And the fourth thing that I want you to understand is that 36 upon 100 is the risk, but 36 upon 64 is the odds. So there can be a risk ratio and there can be an odds ratio. The risk ratio, in risk, the denominator 100 contains the numerator 36. Therefore, a risk can never be 1. The final thing I want you to understand is that if the risk in the operated and the unoperated was same, then the risk ratio would have been 1. So if both treatments were similar, the risk ratio would have been 1, and this is called the null value for odds ratio and risk ratio. Finally, what I want to tell you is the meaning of the word random. So there are two types of things which are random. One is random selection and the other is random allocation. In random selection, you are selecting from the source population because your target population will also come from the source population. And if you randomly select over a sufficient sample size, then all units in the study population, source or target population, have the same probability of selection. Hence, your results on the study population will become generalizable to or externally valid on the source and the target population. So, random selection over sufficient sample size ensures external validity of your results. Random allocation over a sufficient sample size is done on the treatment groups, because this random allocation would equalize both the treatment groups, operated and not operated, in all other factors that can explain the result. Result here was that surgical treatment is bad, conservative treatment is good. Other things that could have explained besides operative and conservative treatment could have been that well operated patients were older. So age could have confounded this explanation, this association between treatment type and good or bad outcome. And this other explanation is called as confounder, and the best method to control known and unknown confounding factors is random allocation to the treatment groups. So this is what I want to absolutely clarify about this table. So let us see how we arrive we arrive at the risk ratios and odds ratios. So we'll use those numbers. 36 out of 100 died in the operated and 6 out of 100 died in the non-operated group. Here is a epi info program which you can download from the internet. It's a program developed by Center of Disease Control Atlanta and is basically free of cost. So you click at this and you have this window. You go to this window of stat calc, and in the second window you go to tables and you make it a large screen so that you can see, and you say that 36 died in the operated group as compared to 64 who did not die. 36 out of 100 is risk of dying given that you are operated, and 36 upon 64 is the odds of dying if you are operated. And you would appreciate that in odds the denominator 64 does not contain the numerator 36, whereas in risks the denominator 100 contains the numerator 36. Therefore, the value of risk can never be more than 1. Then in the unoperated group, we feed the number 6, and the number here would be 94 to make it 100. So this is a 2 by 2 table where the exposure is in the rows, operated, not operated, and the outcome, good result, bad result, good result, is in the columns. And the result is that you are comparing risk in the operated, that means 36 upon 100, divided by risk in the unoperated, that means 6 upon 100, and getting a risk ratio. Now this risk ratio, you can say it is 6, it is 6, 6 sixes are 36, so 6 is the risk ratio. But now there are these two numbers, 2.6 to 13.6, and you see that there is lower and upper written on this. So this lower and upper is the 95% confidence interval of this point estimate of 6. It means that if you repeat the study 100 times, 95 times you will be getting a risk ratio of 2.6 to 13.6. Now I told you that if the risk in the operated and the unoperated was the same, then the risk ratio would have been 1. So that is, a null value for a risk ratio is 1. The null value for the odds ratio is also 1. But since the 95% confidence interval does not contain the null value, that is why these results are significant and they have to be responded to. So one method is of saying that the results are significant is saying that the 95% confidence interval does not contain 1. The other method of saying it is that the p-value is 0.0000, I think goes into crores, 48. That means there are only 48 upon this many thousands, lakhs chances that what you are seeing is by chance. So that is the meaning of p-value. Well, this evidence based approach was used for 10 common orthopedic operations being done in UK. These operations were compared to conservative treatment on these 10 parameters. In this table you see that red means operation was not necessary, it should not have been done because conservative was better. Yellow means that the results are not generalizable, they are not statistically significant. And only green means, these two, that the operated did better than the conservative ones. So only carpal tunnel decompression and total knee replacement survived the evidence based review. And you can expect that such reviews would become higher and higher because people would not like to pay, insurance companies would not like to pay for operations which are not justified by evidence. So by now you have understood that there is a paradigm shift when you take decisions of treatment or interventions at the level of the patient, at the level of the community, at the level of a health ministry, or at the level of the world. And that paradigm shift is that the decisions are not based on what should happen, but what did happen. Therefore, your divorce with maths is to be reversed, as it is the numbers that document past experience to be used to determine the future decisions. This number language you should become masters of so that you are good users and producers of research and can help your patient decide his choice of treatment based on credible evidence rather than plausibility, conjecture, or peer view, all of which belong to the dustbin. And your decisions always remain updated and evidence based by your continuing to use literature to determine these decisions. Therefore, your divorce with mathematics that happened in 10th class has to be reversed. And even as clinicians, you have to start understanding the science of numbers. The science of numbers was developed in epidemiology, this epidemiology, which basically is defined as the study of the distribution and determinants of the pain or pleasure producing event of interest. Now, distribution can be time, place, or person. Basically, epidemiology answers what painful or pleasurable occurred, in whom, when, where, how, and why, and then what should we do. So, this is your introduction to epidemiology, and will now be reviving your mathematical instincts, which you had said goodbye to after high school. So you remember these transition rates from normal to disease to cured to dead to disabled to lost to follow up, the red and green ones. So let us understand a little bit in greater detail about these transition rates. Here is a cylinder containing 20 cc's of fluid. It is filling at the rate of 2 cc's per minute and emptying at the rate of 1 cc per minute. How much would the volume of fluid be inside the cylinder at 10 minutes? Filling at 2 minus 1, 1 cc per minute. In 10 minutes, 10 cc will be more. So 10 plus 20 is equal to 30 cc. So this cylinder will have 30 cc's of fluid in 10 minutes. The formula by which you can determine it is volume at time t will be equal to volume at time 0, that means 20, plus time into filling rate minus emptying rate. Now convert the cylinder into a ward. Here the ward has 20 patients at time 0, and it is admitting at 2 patients per day, which is called as the incidence rate, and discharging at 1 patient per day, which is called as the attrition rate. And how many patients will you have at day 10? Answer is 30. As prevalence at time t will be equal to prevalence at time 0 plus time into incidence rate minus attrition rate. Now, why should there be attrition? Attrition can be because patient got cured, were dead, or lost to follow, or migrated. In chronic diseases, it is usually zero, attrition rate is zero. And therefore, your prevalence formula changes to prevalence at time t will be equal to prevalence at time 0 plus time into incidence rate alone. So if you have two prevalences at time distance, you can always arrive at the incidence rate. So it is important to have two surveys and two prevalences to be able to determine the incidence rate. This is a very important MCQ question. Now, how to understand that there is a red light? By using the incidence rate. So for all incidence rates, rapid transmission will, depending on virulence of the organism, susceptibility of the host, and the ease of the presence of the mode of transmission, will start spreading more at certain time, and that is called as epidemic, and how to use incidence rate to notify an epidemic. So, for example, more than 15 meningococcal meningitis cases per 100,000 population reporting within 2 weeks is a cutoff for meningococcal meningitis, and this demands time critical action, planned action, where everyone knows what to do, when, where, and how. So here is an example of our using, me as an orthopedic surgeon being trained in epidemiology, using the time and place distribution of the acute encephalitis syndrome epidemic in UP and Bihar, which was occurring from 94 onwards when I became the director of AIMS Patna. Now, this epidemic was involving 5,000 children per year, causing disability in 3,000 and death in 1,000 per year. So as the director of PIMS Patna, I thought that if we could sort of suggest a control of it, then we would have a very high reputation. And therefore, we tried to fill the data of the 2012 epidemic through mobiles. The latitude and longitude of the mobile was automatically conveyed into our Excel data sheet. And we use that Excel data sheet in the EpiInfo, in the micro mapping program of the EpiInfo, to get this picture. Now, this is not a snapshot. It is actually a video. And that video is that you start getting these dots as time passes. This is the start, and as time passes, this picture keeps on changing. And what you notice was that first the dots appeared here in the summer. Then in the monsoon, there was this lull. And post-monsoon, this was the picture. Now, I would not wait for you to try to interpret it. But what you can clearly see is that this epidemic is not able to spread to the south as it is limited by the Saryu River. And this is the Gandak River. So what we theorized was that in the summer, since the flow of the Gandak was less, then this epidemic starting somewhere here was able to go down the feco-oral route on the north bank of Saryu and start a problem east of the Gandak, that means in Muzaffarpur in Bihar. Then with the monsoons coming, the fecal contamination becoming less, the whole of the epidemic disappeared. And post-monsoon, since all the small water collections were filled in Gorakhpur area and people were using surface water for fecal cleaning, this was the epidemic that happened in Gorakhpur post-monsoon. So theorizing this, we were able to say that probably the epidemic is by a virus, enterovirus, growing in the intestine, and it was traveling by the fecal-oral route, and the midstream of the Saryu was preventing it, the fecal-oral contaminated water, from going to the south side of the river. So after conjecturing all this, thinking about it, we tried to use this knowledge. We convinced Nitishji, and we were able to do a clean water campaign in the area of Muzaffarpur. So this is what you see. So this is the thing that you see. 2013 are the red dots. See how many of them are there. And 2014 are the purple dots. We'll separate it and show it to you what happened by a clean water campaign. Just chlorine water, chlorine impregnated drinking water. So from 1347 in 2013, in Muzaffarpur, the number reduced to 64 just by a clean water campaign. For perpetuity, acute encephalitis syndrome now doesn't occur. 5,000 people don't suffer, 3,000 don't become disabled, and 1,000 don't die. So after this, when I came back, we started micro mapping the epidemic in a similar manner in UP, and now you find that there is no epidemic. So when you have to decide for your community or the nation about what intervention, how to achieve prevention, which is better than cure, then you have to know the science of numbers. And we will start teaching you the science of numbers if the institution permits. Therefore, not only should you do good research, but you should also be able to communicate it. any research which is just decorating the shelves of libraries or giving you a promotion has not really been used. Therefore, the art of using the research is called as translational research. Now, that is like a common Indian song. ठंडे ठंडे पानी से नहाना चाहिए, गाना आए या ना आए गाना चाहिए. And we sang about this acute encephalitis syndrome. We wrote to the health minister, we wrote to Modi ji, and so we got an appreciation letter for it, and we were able to control this annual epidemic which uh, caused 5,000 to become ill, 3,000 to become disabled, and 1,000 to die for perpetuity. It was so important that the Nobel Laureate Committee, the Socrates Committee, which awards not individuals but institutions, gave the Socrates Award to AIMS Patna for this purpose. So you can understand the power of numbers and where it can reach you, provided you become masters of it.